So the recommendation 4, do you want to read that one out?
The committee recommends that the Department of Health and Aged Care replace the DISCAT grading pathways and recommendations and patient information. So we need to stop the recommendations, assessment, development and evaluations from the DSCAP pathway. Yeah, again, I don't think we need to talk in great depth about that. I think we've covered it. Yeah, we need to scrap that. It's rubbish. It's not helping anybody.
But they did want to move to this grade system, which I didn't understand. Grade is grading of recommendations, assessment, development and evaluation methodology. That's what grade stands for.
Yeah.
I don't know what it really is or what it is. A lot of it is going to be based on the fact that they need proof.
Mm-hmm.
And that we don't have that at this point of time. And that's another thing that's going to be a catch-22 for the patient community.
Mm.
You know, the medical community want proof.
And then is that the new silly word that doctors don't understand? It used to be DSCAT, now it's grade, and doctors still got no idea what that is, what it does, what it means. Yeah. How do you recommend, assess, develop and evaluate?
Yeah, but it is something, I guess, that the RACGP put forward. In their recommendations, they want it to be this grade.
Mm-hmm.
Be nice if our patient community understood that what it was. We could see the
helped us in any way.
Yeah, would it? No. I don't know, because they said, I think one of the things they said, and I've got the paper, I printed it out here. This is from RACGP. They said, well, the above guidance is available and welcome. There is still a need for grade level evidence-based guidelines. That's where it's going to fall over, unless they go overseas and look at the ILADS thing. We seem to be, hell-bent on going with the IDSA guidelines, which doesn't believe in chronicity. It believes that 4 weeks of doxycycline, you're sort of cured at home. And that's why we've got ILADS. It says no,
that the Western blot and ELISA is gold standard, and I can't. I'm not feeling good about that one.
No, this is a political nightmare around the world, and Australia just has to be one of the worst.
I think so too. When I was in Austria 2023, I bumped just in the 10 days I was there, I met people and talked to them, and 2 of them had been hospitalised with Lyme. Both of them were offered a spinal tap to check the presence of Lyme within weeks of their bite and their symptoms developing. They were using spinal fluid.
Yeah.
And that's where they were finding the Borrelia. And then we're stuck on this, obviously I don't think we should spinal tap folks. That's got a risk as well. But let's assume that it's not just swimming around in blood, because intelligent diseases are evading the immune system. The immune system is hyperloaded into your blood.
Yeah.
So they're getting out of the blood as quick as they possibly can, digging themselves into biofilm, digging into the spinal cord and the spinal fluid where the bloodstream is not, the white blood cells are not, and evading. They just want a nice place to live.
Yeah.
And the nicer you can be as their host, they're going to turn your immune system off. They're going to change everything inside you. So
they want to go to a food source, and your food source is your collagen, your manganese, which is in your tissues, your collagen, your blood, synovial fluid, everywhere else but your blood. There's no food source for them, and there's got this stuff fastly going past them. They don't like living there, and they can corkscrew their way anywhere.
Yeah.
And this is the other catch-22 about the ELISA testing and the Western blot or immunoblot testing, is that in the first 2-3 weeks or so, we don't get an IgG and IgM response from.
I think it's 6 weeks even. And in this findings, I think it was Schloeffel said it was 4 to 6 weeks for seroconversion.
Yeah, but the ideal time to be treated is straight away.
Which comes back to that prophylactic treatment that he recommended as well.
Yeah, but then again, when you read about prophylactic treatment overseas, they say it's like 1 or 2 doxycycline. You need a month of it.
Yeah,
that's the prophylaxis is a full month, which given that if you've given probiotics with it, if doctors understand, the good functional medicine doctors do understand you need to keep the gut safe.
So I think for most healthy patients, 4 weeks of doxycycline has a lower long-term risk than not treating a tick-borne disease. I think most people can recover from 4 weeks of doxycycline with a minimum of fuss versus a lot of people cannot recover from 20 years of Lyme that was not treated. That's not true. So I'm going to reframe that. Recovering from 20 years of Lyme that's been not treated or poorly managed is possible. It's just time-consuming, expensive, difficult, full of hoaxes and roadblocks and missteps. And it's possible, but it's not easy. Yeah. 4 weeks of doxycycline is fairly easy and cheap by comparison.
Yeah.
And even if you get some candida and your gut goes out for a period of time, it's still a simpler thing to recover from, I think, for most people.
And look, if you've got doxycycline, we'll say doxycycline. And again, we're not recommending this. We're not making any
medical recommendations saying what the ILADS guideline is.
You're just saying that as well. Mm-hmm. But look, it covers rickettsias. It covers doxycycline as well. It does cover the rickettsia. And if you happen to have a Borrelia, which we don't know, we can't test for, and it's an Australian thing, well, lo and behold, you might have the chance of overcoming that as well if it's there.
So your guidelines in Australia are 10 days of doxycycline. And even if the patient shows improvement, they're not eligible for another course.
Well, the thing that I do suggest to people, and again, it's only from my personal experience as a patient, was to try and see an infectious disease doctor and talk about the ricketsias and the Q fevers. Do I have that? Don't go into the other sort of things. But you will, I did get 4 weeks initially. And then when I said to him, look, I'm still unwell, he did ring up and get permission to get another 4 weeks for me as well. So that is on the table.
Which I just find so mind-blowing. So he needs to get permission
for
rickettsia. But if you were to have acne or rosacea, you could have 6 months or 2 years of doxycycline. So my brain can't hold both of those things together. So you can't be ugly, but you're allowed to die.
Yeah. Or let's not say die, but let's say that allow the infection to become endemic throughout your whole body. It is a bit of a tautology, isn't it? It's one of the things you don't understand fully. But there's also things like we don't really have any good testing to prove that this infection has been eliminated.
No, we do not.
Tuberculosis, you do. You test, you get a double negative test. You do it 1 month, and then in the next month, if it's still negative, then they can show that it's proved. But it's a minimum of 8 months, generally, of an antibiotic.
Pretty strong antibiotics
for tuberculosis. They don't want you to become sick.
They don't want you to become contagious.
Contagious, yes.
They don't want you to infect other people.
All right, so that's recommendation 4, which is the grade guidelines. We'll have to get our heads around what that actually means. It'd be nice if they did have patients involved with that again following.
And are they just saying with that, replace the DSCAT clinical pathway with the grade guidelines? Whereas the one before, they said, what should we replace it with? And now they're saying, we've already decided it's going to be grade. I feel like I'm misunderstanding something.
Well, I think the DSCAT means it's become a name of a condition.
Okay.
Because on the website, if you type in DSCAT, you get tick-borne infections.
So they're using it as the noun and then the verb, which is a clinical pathway. Okay.
Yeah. So they develop a pathway which should have led to guidelines.
Yeah.
The pathway shows, has this person got a tick infection or not? Well, what is the guideline? If he says yes, well, the guidelines state you take, as you said, 10 days. I'm sort of saying an infectious disease doctor should give you 4 weeks and have the ability.
Because I'm just in the field and saying what I see.
Yeah. Well, again, there's an inconsistency.
Doctor to doctor, it's different. It's state by state, it's different.
The uniformity needs to come from, I guess, a federal level, whereby the best in Australia get together and say, look, we really need to have all of this on the table, all kinds of treatment. And if the patient remains unwell, then they're allowed to continue to treat.
But, yes, and that makes sense, doesn't it? If they had improvement to symptoms and then they stop the treatment and they relapse, it indicates that we need more treatment. If you went to hospital with sepsis and an antibiotic didn't work, you try another antibiotic. If you took you 3 days and you were still septic, they'd still give you more antibiotics. I feel like it's the same in tick-borne diseases.
Yeah.
If you have an infection and it responds, and then you take away the treatment that it's responding to, and then the symptoms come back, we need to keep treating. And I'm a naturopathic. I see so much value in herbs in initial infections and in chronic ones. But I do think there is value in initial infections being treated with antibiotics and herbs.
Yeah.
Not one or the other, but both in that stage. And I pull one out and people get sick. If they don't have access to what they need to stay well, we are setting people up to fail. and then washing our hands of that. And it doesn't sit well with me at all.
I'll add a bit of a caveat to what you just said, that if the infection is a different infection, you will need a
Run more
different
tests,
treatment
find more
approach.
antibiotics. This is what we do. If the person hasn't responded, is there another infection here?
Yes,
this is the standard of care for other diseases.
Yeah, we will need to add that. And that's where a functional medicine doctor, someone who's got a broader range of understanding.
It should be every GP. It should just be the tick panel. When you tick it at the back end of I'm writing this prescription up and they're going to go and get a pathology request now, the tick panel should be all of the tick-borne infections in Australia, not just they have to know with their knowledge, I'm going to tick rickettsia. There's 3 kinds of rickettsia that I can test for with this particular lab. I've got to find them all and remember their names. Don't make it hard for doctors to win. Put the 12 infections that we've got, whatever it might be, stick them all in the one box and check every single person with a tick bite. Check them for all of them. The circus that I go through with patients that come to me saying, I've got a recent bite, all the infectious symptoms, it's definitely a rickettsia infection. It's definitely, and I'm like, well, is it more than one rickettsia infection? Did they check for Borrelia, Bartonella, Babesia? Did they ask any other intelligent questions here? No, they did not. And the bloods have to be within 10 days old or they can't be reused. So by the time that person comes to me, they're now needing a new blood draw. They've wasted weeks and weeks of their life. We need to ask the right questions at the right time. And that means we've got to set our doctors up to win. Doctors cannot be experts in everything. We need to help them here. And that's what I would love to see come out of these Department of Health and Aged Care, actual guidelines that make it easy for doctors to write all the tests into one.
So coming to that, would you simply only say, look, if the patient says, I've never left Australia, I have been bitten by a tick and they know they've been bitten by a tick, and certainly tick were recommended, hopefully the people have saved the tick. That's another.
But even now, where do you send it to? We used to send it.
Yes, we don't.
Australian Biologics, we don't have anywhere to send it to anymore.
We don't have anywhere in Australia at the moment that we can do that. We do, look, ARL do collect ticks, but I don't think that they do give the patients the information from that. But that would be interesting to have the conversation with ARL if they would be willing to do that.
To actually test the ticks, yeah. Especially in like little people. Like the mum saved the tick very often. She's got it in the freezer. Can we just check the bug before we jab the baby?
Yeah.
3-year-olds are hard to get blood out of them. It's hard to get treatment into them. Let's ask the tick if there's a problem first.
Yeah.
But then we've got to be asking intelligent questions of the tick. We've got to be asking not just, have you seen Borrelia burgdorferi? What have you really seen?
Yeah, well, that's the interesting thing, though, that if they haven't proven, I mean, look, within the ticks in research for animals, they have found lots of infections. I mean, I've posted all about. There's anaplasma, there's Babesia, there's Bartonella, there's Ehrlichia, there is Borrelia, there's a number of different strains of Borrelia. They're all in our ticks. But at this point in time, the only 2 that are recognised as being harmful to humans are the rickettsia strains, and there's a number of them. And in each state has their own kind of location of different sorts of rickettsias as well. So if you're WA, you get a kind of different one. So South Australia and Tasmania have a very similar one, and Queensland has a different one again, and New South Wales. And Q fever, which is mostly, I think, the northern states. But if they say, look, yeah, we did find Babesia and we did find this other thing, they kind of say, well,
that doesn't transmit to humans, so it's
well, they haven't found that proof, and that's what we're hoping that. We're hoping, to be honest, I was hoping that Murdoch University was able to do that.
Or the CSIRO study. It was the finding in the CSIRO study from
but they need
2023.
human harm proof, and we haven't reached that point yet. So that is another bugbear with all of these recommendations.
Yes, they just say, we found this. We should find out, does it infect humans? Yes, we should, or we can extrapolate data from overseas when we know that it does.
Yeah, look, the recent Murdoch University research was 2 papers. The first paper actually showed that the 6 patients, they only did 6 patients, and they have, and the report at the moment is only a 3-month follow-up. They are supposed to do a 12-month follow-up after this as well, following those same 6 patients. At this point, I don't think I have an understanding whether those patients were treated, but they did find rickettsia. I'm not sure in the full 6 patients, but they did find rickettsia, but nothing else. So that was found in the patient, not necessarily in the ticks. So I don't know what they found in ticks. the reports were pretty complicated. They're very scientific and data driven. And look, and that would be interesting to know. And they did find biomarkers that at the 3-month mark, these same inflammatory and other kinds of biomarkers they found at the time of the bite carried on 3 months later. Now, do they find that come 6 months, 12 months later? I don't know. We'll have to wait.
Or 20 years later?
Yeah.
Yeah.
I don't know. Yeah. I don't know how long they'll be following up. But the thing is, they're only going to fill up 12 months. But we do need a lot more constant, fully funded, millions of dollars of research into this ongoing.
And because we've got the chronicity here, the long Lyme, the not responsive to treatment Lyme, whatever you want to use the words, we need to be following patients for years. As we've discussed already today, Lyme can spring out in 15 years' time after a car accident. Lyme can, from your travels or from your mouse bites, or from a sexual partner. It's a low transmission rate through seminal fluid, but borrelias have been found in seminal fluid and vaginal secretions.
Yeah.
It's transmitted mother to child. So if your mum went overseas, could you have Lyme? Absolutely you can. It's congenital and passed in breast milk as well as crosses the placenta. So we just need to stop poking and pretending that humans are isolated. We're not. We go overseas. Australians are extremely well travelled.
Yeah.
You don't meet many Aussies who haven't been overseas or had their mother been overseas.
Yeah, we've got this disconnect between the patient's reality of all of this and the scientific and the research thing. And with my background as a scientist, I can kind of understand the 2 points. And a patient, being a patient myself, I've got frustration as a patient, but then my head kind of goes, the science needs to show the proof of all of that. And I understand that. But in the meantime, patients are waiting and waiting and waiting and just getting sicker and sicker and sicker. We have to stop that divide. We have to, while
we need to trust
the research
people.
is going on, we said, look, for me, the ideal thing is clinical, and just say, look, we're unsure, but clinically we strongly believe that this was what's going on. Let's safely treat these patients, oversee them, make sure that they don't crash. We're not giving them this really bizarre stuff that sometimes might happen. Safe things, whether it's off-label stuff as well. Let's see what these patients do, and then report on them. That's the only way to do it. I mean, get patients' permission. They would rather be treated and have the hope in some kind of treatment process than sit around going, well, we can't do anything. And
we are unwilling to do anything, which I think is more harmful.
Well, yeah, there is this do no harm concept, but he's doing nothing harmful. And I'd have to say yes in this case.
100% with my patients it is. Absolutely.
Yeah. All right.
Absolutely.
All right, let's go.
Recommendation 6.
Suite of fact sheets for the public and guidance notes. Yeah, look, they did produce
recommendation 5, fact sheets.
But look, I did not see constant promotion to the medical profession about where they lived, and even the name discount. They're going, what's discount, So if they change that, I mean, some of that information was really quite good, but it was very hidden. For the patients, though, it was too hard to understand. We need some simple, basic communication with what a tick looks like, what to do for prevention with lots of images on it. Some really basic stuff needs to be done. I mean, Tickness produced a really good brochure on that, and it's very common sense. It's very easy to understand, get your head around what to do, what not to do kind of stuff. We need the government to do that. I mean,
absolutely. This isn't difficult. Get it into schools, get it into GP clinics, get it into nursing stations, get it into camping stores, get it into Scout. Get that education happening in our children so they're not suffering in 20 years' times.
And to your workers, your forestry workers,
absolutely.
So many patients.
Your mining people are outside as well. There's so many people who are outside for their profession. Ironically, in the male patients I've seen who have had high-level jobs in mining, they have been believed far quicker that they were sick than most of my female patients.
Yeah.
We believe men when they tell you they're not feeling well. When a woman's not feeling well, she's still just hysterical. She needs antidepressants. It is still that is a thing we need to be
That was raised, was the gaslighting, was raised in the
Absolutely,
by the
over and over in the
senators.
patient stories.
And look, and we did a survey last year, which I can't remember where I've put it out, but I did actually apply for some grants, and I did put that survey out, which our community did. And 82% of the people within my conquering chronic illness group, which looks after patients, were female.
Yeah.
And yeah, I mean, reading the stories of them, I mean, even I've been gaslit as a male, but females get it so much worse. It's terrible what they have to go through, you know.
Yep.
And that has to stop.
Yep. And especially the other bias that I see is that if you can keep your cognitive function, which not everybody can, depending on where they got bitten, what infections they've got, people are believed more when they've got their cognitive capacity. It's easier to understand them. And a higher socioeconomic background or higher educational background seems to be able to advocate better for themselves and is believed quicker. And that is not okay with me. Believe every person who stands in front of you that says they are not feeling well, not just the one that's got a degree and dressed nice today or that can string a sentence together lucidly still. That is not okay.
Yeah. And we've also got the issue with not necessarily funding, but the fact that so many of us have lost our jobs. We simply cannot afford to see the better practitioners. Your functional medicine practitioners do cost you a lot more money, but
supplements are expensive. I pay wholesale for stuff, and I'm flabbergasted by how much everything costs.
Yeah,
it's supplements are expensive. Treatment is expensive. Functional medicine clinics and insurance and receptionists, it's expensive. This stuff is not cheap.
It is. I used to run a business. We know the back end stuff of what running a business is like. But the poor community that I look after or involved with, they've lost their incomes. They can't afford to even put food on the table and their rent and so forth. It's terrible, which is why we need
$5.20 a week, I think, at the moment for a disability pension.
If you're lucky to get a disability, that's the other issue too. And that's
when average family rent is $700 a week, I just can't make the maths.
Yeah. And that's where we do need more funding for our community as a whole. We can't just say, look, I've gone and seen a doctor and we only get $27 back or whatever it is the basic minimum. When the doctor costs you $250, I think the maximum I get back is $80 or something from a $250 visit. Now, I'm not saying my doctor's not worth that. He's very much worth that.
Absolutely.
Very much worth that. And then sadly, the people can't afford the doctors that I see, which I'm very fortunate to do, although I'm living off my home phone to do it. The other people could just see a normal GP, and then they're in this thing that they don't have the understanding, they don't have the qualifications, so they're in this catch-22. They won't have a chance of getting better because they don't know what the functional medicine doctor goes.
Well, they can't afford it. They just can't afford to go. And then functional medicine doctors, because they're in the APRA system and the AMA is watching them, they've got guidelines, so they need to have a test that justifies a treatment. So when they get audited, everything looks good at their end. How do you keep affording the testing that's required for this functional medicine doctor to give you the drug?
Yeah, that's another catch-22. There's a number of catch-22s and all of them.
Yeah, I get it.
Kind of have to unravel and get them to understand fully. So, yep. All right, so that's
that recommendation 5, which is more fact sheets for public and more guidance notes. I think brilliant. That's what we all need.
Yeah.
And we need it in a timely manner, and we need it in alignment with the idea that tick-borne diseases actually make people sick and they can be chronic. If you don't have a bullseye, then you don't have a tick-borne disease. Please leave my office, which was one of the things that came in the Senate inquiry. I don't know if we'll have time today to go through it, but maybe we should. I'll record it and split it into 2 different things.
Yeah, well, there's an urgency about that. There's an urgency about the education of the public.
Absolutely.
We don't want more people to join our group.
No.
We don't.
No, we do not. God,
it's not a fun group.
In my submission to the Senate, which they didn't quote me at all, I was very disappointed. I said to them, look, I would love to not be in this world. I would love to go back to preconception care, healthy mums, healthy bubs, happy stuff. Just a little bit of like, I'm tired and I'm a little bit constipated. Wouldn't that be amazing? Rather than like the witnessing and the holding of the suffering and the despair that is my job, and the complex solutions that I have to find, and the micro steps to walk people through this stuff, and the risk with all my MCAS patients, which is 60% of you now. A micro drop of something and they're in bed with a migraine for 3 days. I'm responsible for that. But also I know we've got to get them well, and you can't get well by doing nothing. So I would love for these people to get better help the whole way along and have more multidisciplinary options here available to us, because I fully believe that naturopathy is incredible at long-term recovery.
Yeah.
And sometimes I need my patients to be able to access a pharmaceutical, and I would love for them to be able to access a blood test and have it bulk bill, please. We need all of it.
And that's the trouble with the wording of Lyme, and I know that people get upset about that, is the fact that it's actually put a damper over the fact of the rickettsia and the Q fevers have been less recognised, and yet they are the most recognised. They're the most prolific in our ticks at the moment that we know of. But yes, there are other Borrelias. And if we talk Borrelia rather than Lyme, I think we'd be far more accurate in description at this point in time, although I've got questions from the past. And I put that in my set an inquiry. I think I put the most number of extra documents in mine as well, Hector and myself too.
Nice.
So I've still got to answer questions, but look, let's move forward. That's the most important.
Absolutely. How are we going to fix this so that more people aren't suffering? But what are the factors in increasing tick bites in humans? It's population density, it's habitat loss, it's loss of large mammals because of habitat. So then the ticks still exist. They're still hungry. They're just looking for someone to have a nice meal and make a baby themselves. They're just insects being insects.
Yeah.
They're going to find a new food source, and that's us.
Yeah.
And some of that is climate change driven. Some of that is human decisions around planning, and the way we manage wildlife corridors.
Yeah.
So, that's a big picture.
And the other thing is, not to be fearful of, we want people to continue to go out and enjoy Australia. I mean, Australia is a fantastic and beautiful country. When I worked as a geologist, I had the opportunity to travel around most of Australia, a lot of Australia. And it's brilliant. And look, like, you can still enjoy the sun, but just wear some safe sunscreens, safe sunscreens. And you can... at the moment they're saying if you want to enjoy going out in Australia, well, please wear mosquito spray. Well, the same thing applies. Please still enjoy Australia, but just put on your repellent so that you don't get bitten by ticks.
And know what your early interventions are. You get bit, you get the tick off as quickly as possible. The longer it's in, the more it can give you. And get onto treatment straight away, even without symptoms. Start my herbs. Start herbs that target tick-borne infections and boost the immune response.
Yeah.
Get yourself lots of vitamin C, lots of zinc. Get onto the herbs straight away, even if you don't have symptoms. And then if you have symptoms, instantly to your GP, instantly the antibiotics. The quicker you manage all of this, the better it is.
Yeah.
If you have any weird symptoms after a tick bite, you cannot ignore them.
Yeah. And what you're just saying there is from your clinical experience. Your clinical experience should be passed on to become a part of a guideline.
Absolutely.
It should be, they're safe, they're not going to be harmful to people, but you're saying that quite now is not something that a doctor will go and go, oh, well, I heard this, I'm going to do that. We should form a proper community of people who are part of that guideline process, which you would be one, functional medicine doctors would be others, not myself because I am a patient. I shouldn't be involved in that side.
Well, I think there is still, as a patient advocate, I think you are hugely valuable. And the way your brain collects data and understands data and collects and remembers, you have so much to offer.
That's me personally.
Yes, you personally.
Okay. I am a bit of a nerd in regards to all of this, I must admit. I'm a bit of an outlier about that. But look, the LDAA should be involved with this, definitely.
Absolutely.
Their experience and their knowledge and the great people that they've got involved with too. Yeah, you're right. We should have patient advocates. We should have the Australian Patients Association and other patient associations on our side as well, advocating for us to be a part of this process, not left out, because guess who it's for? It's for us. It's for patients. This is all about patients. If you want to understand this, talk to patients. Basically.
Absolutely. And believe them.
And believe them, exactly. I mean, I was at the peak of my career in my 40s when I got sick. Why would I choose to just want to lie on a couch, for gosh sakes,
if you were that good at manifesting, you would have got yourself a pony and a Ferrari and $1 million. You don't manifest this. Nobody is that good at calling down stuff from
No,
God.
I did not choose to do this, to sit on the couch all the time. That's for sure. I had 2 young kids, a lovely wife, which I've still thankfully got a lovely wife. And I can, 22 years, I the peak of my career, probably still working,
Absolutely,
still
would be right
enjoying the
now.
photography career that I had. I was traveling around the world educating other photographers. I loved it. I loved photographing weddings, believe it or not. But anyway, we should move on. The community